Okay. Now there is some term called Uthoff's phenomena. Okay. Uthoff's phenomena, what does it mean? Okay, in these patients of multiple sclerosis, you will find a history that when the patient takes hot showers, the patient deteriorates further. So why it is happening is hot showers trigger these T cells, okay, and this binding, and there is further autoimmunity, and which further goes and deteriorates these axons, and there is further conduction block occurring, and those further conduction block leads to the further deterioration. Okay, very basic. Okay, let me just just remove these. It looks very complex. Just a minute. Okay, I'm sorry for the loss of the precious time. Okay, so I want to say, as we have already ventured through the topic, now you all know there is something called T cells, there is something called B cells, there is a BBB, that is blood brain barrier, and these things hamper it, in the presence of integrin binding. These causes further worsening of this patient, as the axons, there is conduction blockage and axonal destruction. Okay, now there is some group of drugs that we'll see further acting here and acting here, which stops this. What a great thing. Like, there is some drug called natalizumab. Okay, natalizumab. Okay, which stops this phenomena, and so as stops the further worsening of our case, and it acts here. Okay, it stops this binding of T cells with integrins, and also that stops the hampering of the BBB, and further stopping the further axonal destruction, and further worsening due to conduction blockage. Got it? And on the B cells, likewise, there is a drug called ocrelizumab. Okay, ocrelizumab, which acts here and works on the similar fashion. Okay, now enough of this representations and all. Let's dwell into a little bit of theory. Okay, so pathologically, perivascular lymphocyte infiltrate and macrophages lead to degradation of myelinal cells surrounding the neurons, causing symptoms that vary depending on lesion location. Okay, we will see there is a deposition of plaque at various locations, and so the various presentations, the various symptoms, and the various signs, all these varies depending on the location. So just to give you a brief idea about the locations, it can be intratentorial, okay, it can be periventricular. Okay, we'll see that. So these clinical symptoms, characterized by acute relapses, typically appear first in young adults, following a gradually progressive course leading to permanent disability within 10 to 15 years, as it keeps on worsening, as we have already discussed. Okay, so before that, let's understand the basic of it through this better diagram. So as we are seeing this, the T cells and B cells invade the CNS through the permeable blood-brain barrier. Now we know the mechanism behind all this. Okay, now these T cells interact with B cells and microglia and astrocyte. T cells, B cells. Then there is antibody and cytokine release. Okay, it binds to microglia, T cells, and it binds to astrocytes, causing further damage. Oligodendrocyte also. There is like demyelination. Further remyelinating capacity exhausted, can't remyelinate. Okay, then there is neurodegeneration in the brain parenchyma of the neurons. You can see this destruction happening. Okay, so there is a leaky blood-brain barrier. As we know, the blood-brain barrier is exposed by that the linkage of T cells with integrin that we have already understood. Now the T cell and B cell entry is there, autoimmunity is happening, then there is activation of microglia and astrocytes, then there is antibody and cytokine release, then there is oligodendrocyte injury, followed by demyelination, followed by failed remyelination, because our body attempts to just physiologically attempts it to cure things on their own. you know that very well. But here it is not happening because your own body is not with you, it's against you, autoimmunity. So there is at last neurodegeneration. Okay, yeah. So yeah, there are like 7 categories if you classify multiple sclerosis in. And this, like, the most commonly initial observed is relapsing remitting. Okay, there is a relapse, then there is, automatically it is like cured, and again there is relapse. So this initial onset is observed in 70 to 80% of cases of multiple sclerosis, and characterized by the new or recurrent neurological symptoms that are consistent with multiple sclerosis, symptom lasting like 24 to 48 hours. Okay, and symptoms developing over days to weeks. So, and there is another type, that is like primary, one sec, yeah, primary progressive. Okay, primary progressive. This course presents in 15 to 20% of the patient and shows a gradual deterioration from onset without relapses. Okay, yeah. Then there is something called, obviously if there is primary, then there will be something called secondary. So secondary progressive, following an initial relapsing remitting course. This course marked by more gradual neurological decline. Okay, superimposed relapses can occur but are not mandatory. Okay, so yeah. Then there is something called progressive relapsing. This course involves gradual deterioration with superimposed relapses, as seen in 5% of cases. And additionally, there are 3 more categories. So there is like clinically isolated syndrome, there is fulminant, and there is benign. What do you mean by these? Let's discuss. This clinically isolated syndrome is a single episode of inflammatory CNS demyelination. Okay, now the fulminant, it is like severe multiple sclerosis with multiple relapses and rapid progression towards disability. Okay, and the benign overall is a mild disability course with rare relapses, as this word is self-understood. Okay, so when discussing multiple sclerosis, clinicians clinically commonly focus on the relapsing remitting course due to its high prevalence among affected patients. As we have discussed, like 70 to 80% are exposed to this type and category. So the relapses and relapsing remitting multiple sclerosis often show a very partial or complete recovery over weeks or months, sometimes without treatment, as I have mentioned. However, residual symptoms from these relapses without complete recovery can accumulate over time and contribute to overall disability. Getting it? So the diagnosis typically requires evidence of at least 2 CNS inflammatory events. Very important. Yeah. Okay. So let's go through the main important here. Yeah. So the entails that episodes must be temporarily separated and involve distinct location within the CNS. It depends now where the plague are depositing. So the prompt diagnosis of multiple sclerosis enables the timely initiation of the disease modifying therapy, 2 of the drugs which we already mentioned, how they are acting. And the goals include decreasing relapses and MRI activity while minimizing permanent disability. Okay, we go for symptomatic treatment and things like that. Addressing various patient concerns such as bladder, all the symptomatic treatments. Okay, whatever the dysfunction is going on. So before this, first we'll discuss this. Yeah. So although the multiple sclerosis cause is like unknown, the etiology is unknown, but the factors are divided in like 3 categories. Okay, like 3 categories are the most common causes. Okay, the immune factors is autoimmune condition, environmental factors, okay, and the genetic associations. Very important. Genetic, there is a polygenic inheritance. Okay, polygenic inheritance. Yeah, what I was going to discuss with you. Okay, so let's discuss it here. Okay, just a sec. Yeah, so the we are talking about now the causes. So it is very now studied thing that vitamin D3 deficiency can expose or can cause a higher risk of multiple sclerosis. Okay, and this is followed by polygenic